Now we have another speaker, Mr. David Goldhill, who is a CEO of a company, and he's going to be discussing catastrophic care, why everything we think we know about healthcare is wrong. He's had a notable cover story in The Atlantic, as well as the author of, a bit of a stark title here, How American Healthcare Killed My Father. So certainly Mr. Goldhill has a bachelor's from Harvard University and a master's from NYU, and he'll be speaking about his experience with the healthcare system. Mr. Goldhill?
Hi, my name is David Goldhill. I'd like to talk today about the possibilities for American healthcare to serve a different master. I'll come back to what that means, but let me explain first how I got interested in healthcare. It's not what I do for a living. In 2007, my father walked into a hospital late one night because he was a bit short of breath. They held him for observation. Through a series of unfortunate incidents, within 24 hours, he had the first of a series of infections acquired in the hospital, and he never left that hospital. He died 5 weeks later. That obviously was a defining moment of my life and my family's life for many reasons. But roughly a month after my dad's death, Atul Gawande published a piece in the New Yorker magazine about Peter Pronovost and efforts to reduce hospital-acquired infections, a subject I knew absolutely nothing about other than what happened to my father. It's in that article that I learned that the estimate was as many as 100,000 Americans might die every year of infections acquired in the hospital, and that many of these were regarded as reasonably preventable, and that Dr. Pronovost had a protocol, a fairly low-cost series of hygienic steps that had been found to meaningfully reduce the number of these infections and the number of fatalities. And by meaningfully, if I remember right, the article suggested 2/3 to 3/4 of many of the hospitals that had adopted these protocols. So an alarm bell went off in my head. I'm a businessman, as I mentioned, not a healthcare businessman, but I'd been involved in running a movie theater chain. And in this movie theater chain, we had a rule about soda spills and how much time you had before someone had to clean it up, before there wasn't a disciplinary measure. Now, you may think spilling a soda in a movie theater is a matter of liability to prevent someone from slipping and falling. But in fact, for us, the issue was a lot of our business is Friday and Saturday night. For many young couples, that's date night. They've hired a babysitter. It's a big night out. If the first thing they see coming into your movie theater is a soda spill, it feels like less of an occasion, less of a special night. And they're more likely to try a different movie theater for next date night. It was important to our business. And as I thought about this piece, Gawande's piece that I was reading, I said, wait a minute. How is it possible that matters of life and death, not mere optics or environment like in the movie theater business, didn't create enough of an incentive for hospitals to adopt these protocols that had been found to potentially save so many lives? Why wasn't it automatic? And in doing so, I began thinking about what are the incentives in healthcare that can help explain what all of us see as large elements of dysfunction, whether it's very high prices and questionable value associated with those, an enormous amount of complexity, a tremendous plague of excess medicine and the consequences thereof, terrible customer service, poor adoption of information technology, basically the lack of things that we see in almost everything else in our lives. Is it possible that rather than, as so many people argue, healthcare is uniquely dysfunctional or irrational or subject to things that are so different than the rest of our lives, that what's going on in healthcare is something very different, which is that the incentives for good behavior are not as strong as they are in other industries and other human activities, and the disincentives for bad behavior are also not as strong as we see elsewhere. That the whole thing can be explained as a matter of incentives. So my interest in healthcare began then, and based on the sort of exploration of that core idea, I've written quite a bit and spoken quite a bit and learn a lot more every day. And I really appreciate your inviting me to share some of these ideas. I wish I could be with you to have more of a discussion, because I really do learn a lot every time I have a chance to raise these points and hear how they're reacted to. But I'd like to explore this idea that the issue in healthcare is fundamentally one of incentives that we've provided healthcare as an industry. Now, I know for many people it's uncomfortable to think of healthcare as an industry. And I suspect that one of the reasons that we haven't been as rigorous in applying some of the accountability to healthcare institutions is because it's an uncomfortable thought. There are many people who are uncomfortable with the idea of people making a profit in healthcare, with corporations and institutions in healthcare that can make a profit, but they don't think through, I think, fully the issue that all human activities involve earning a living. And that even in institutions or in countries where healthcare is completely a public activity, of course, all the people working are still earning a living for themselves and their families. Incentives rule everywhere. At the core of this incentive, I would argue, is the choice of customer we've made in healthcare. Now, this is something that I think is not often thought through. We've made, and many other countries have made, a decision that healthcare will be subsidized, will be supported, that people will be protected against very high healthcare expenses through safety net programs, insurance programs, private and public. What we've done in healthcare is though a little different than what we do in other areas of the economy where we have safety nets or insurance. In healthcare, we've turned that intermediary into the actual customer. Why do I think this is so important? You know, I like to turn back to 1965 to give an example of how this works in practice. 1965 was a very big year, of course, in the American healthcare world, because it's the year that Medicare and Medicaid were enacted. And this concept of insurance as the primary customer of the healthcare system was really established. Obviously, we've seen some of it in private insurance. But with these government programs, for most Americans now, there's an actual intermediary between them and the purchase of healthcare, either an insurer, CMS, the agency that runs Medicare, state Medicaid agencies, what have you. We stopped being the primary customer of the system in 1965. 1965 was also a very important year in the computer industry, because it was the year that the very first commercial mini computer was offered. It was called the PDP-8. It was created by the DEC company, a very famous name in the computer world that doesn't exist anymore. That's long gone out of business. And what's interesting is the price of this mini computer was $18,000 in 1965. That's a very expensive product, and it wasn't a consumer product, right? But it was the first time that somebody thought, you know, it might be possible to sell computers just to normal companies to use for their data processing work. It doesn't have to be NASA or GM or the IRS or the Defense Department that is the customer of a computer. We can actually make a mini computer, one that would work in a more normal environment. That was a revolutionary idea, and of course led to the change in the computer industry. In 1965, the average bill for healthcare for the average American was roughly $225 per year, which meant, give or take, that the most accessible computer in 1965 was 80 times the cost of healthcare. Certainly not a consumer good. I think you know where this is going. Flash forward to today. Today, I've now been in this for a few minutes, and I'm already missing my incredibly powerful mini computer that I carry with me everywhere, my smartphone. The smartphone does far more than the PDP-8 did. It's far more storage, more processing capacity, and of course, as you know, it does everything, right? It can tell you where to have dinner, tell you how to get there, make a reservation, and even find you a date. It is extraordinary, and it fits in the pocket. And many people decide on which one to buy on the basis of how cool it is. Now, we sometimes, because we've lived through this revolution, forget just how extraordinary it would be. In fact, in 1965, if you had said, in just 2 generations, almost every single person on Earth is going to carry a computer so extraordinarily powerful that it does things we couldn't even imagine today, the presumption would be, well, I guess everybody's going to get a computer science PhD. It would have been inconceivable that you could have turned the least accessible product on earth into the most accessible product on earth. The average price of a smartphone around the world is roughly $250. I know many carry those that are more expensive, but roughly $250 will buy you a smartphone most places in the world, and about 2 billion people are carrying it. And we do expect within a fairly short period of time, almost everyone on earth will have one. What's happened in healthcare? Well, in healthcare, everything has gone in the opposite direction of ease of use and accessibility and price. So today, the average smartphone, as I mentioned, roughly $250. The cost per year of healthcare in the United States per person is $10,000, just under $10,000. So we've gone from computers being 80 times the cost of healthcare to healthcare being 40 times the cost of computers in just 2 generations. And if you Google why healthcare became so incredibly expensive, overwhelmingly the response, the most likely article you're going to find, will blame technology. And when you think of that contrast between the 2 industries, technology doesn't seem like such a great explanation. What's interesting is that in 1965, the 2 industries went different directions in terms of who the customer was. And in computers, we went from just the average big company to the average company, to the individual, to anybody. My young children can use smartphones. And if you think about the amount of innovation, not just in quality, but in the range of services, the accessibility of those services, value, cost, you name it, that occurred because we said the customer is going to be the individual. It's extraordinary. This is the most competitive market, one of the most competitive marketplaces on earth, and certainly one of the most innovative. In healthcare, not just here, but around the world, we have shrunk the number of customers in the theory that we've made them more powerful, given them more leverage. But what's happened? Prices have gone through the roof, not just here, but everywhere. Value considers to be is erratic at best. Quality is erratic at best, and safety remains an important issue. A lot of people don't like the comparison of any industry to healthcare, and I argue intellectually that's part of the problem, is viewing healthcare as so different from other human activities, with so little to learn from anything else, has been one of the reasons that we haven't seen things that should be fairly obvious. Now, of course, in healthcare, unlike computers, most of us believe we need third parties to protect us against an extreme healthcare crisis that's unaffordable. And that obviously doesn't exist in the computer industry, where things feel more discretionary. But let's look more carefully at how that's actually played out in practice. I run a now 500-person company, and a couple of years ago, when I was writing my book, Catastrophic, I looked at a single employee starting out in our New York office and tried to estimate how much of her earnings over her lifetime with us would go into healthcare. So that's everything, right? That's her share of health insurance and our share of health insurance, because of course for us, it's just compensation expense. If we didn't have to pay for health insurance, that money would almost undoubtedly go into salaries, and economists of both left and right agree that benefits are just a form of compensation from a company's point of view. It's her Medicare tax, and it's the share of her state income taxes that go into Medicaid, and the share of her federal taxes that go to subsidize the parts of Medicare that are subsidized and pay for Medicaid. It's her out-of-pocket spending. It's her premiums when she herself becomes a Medicare patient or a Medicare beneficiary. So let's look at that. I started her off at 25, and I said, we'll marry her at 30 and have a couple kids. I actually had her husband leave her at 65 just to make the math simpler. But how much money is this woman, who in the book I call Becky, going to put into our healthcare system over her lifetime? So I don't know what number you guessed, but keep a number in mind, and let me tell you what they are. If the cost of healthcare grew by 0 over Becky's lifetime, literally 0, but her income grew by 3% a year, which traditionally was what a middle-class person could expect in this country. Becky would put in $1.2 million into the healthcare system over her lifetime. If the rate of inflation was what the CBO at the time was estimating for the first 10 years of the Affordable Care Act, and then zero for the remainder of her life, the number went up to 1.7 million. If she had a working spouse who earned roughly the same as she did, their family together would put in roughly $2.25 million. These numbers, in addition to being unimaginably large, are important because they demonstrate something about our insurance-based system that we've forgotten, which is healthcare, because it's one of those goods that is universally consumed, can't possibly, the expense of which can't magically disappear by just shifting it around amongst all of us. For her protection against an extreme illness, Becky and her spouse, if they're working, are putting $2.25 million in, and she's middle class. So the two things I assumed is that she stays middle income for her entire life, and they never get really sick, anyone in her family. It's an extraordinary amount of money. Why is it so expensive? Well, it's expensive because insurance, of course, is the most expensive way to pay for anything. It involves an enormous amount of administration and underwriting and negotiation. It makes everything very costly. Food, obviously, is absolutely essential. We wouldn't think of paying for food through insurance claims, but an enormous amount to every transaction. 15, 20, 25% off the top of Becky's spending is just the administration of the payment system. Now, again, remember, this payment system is designed to protect her and her family against disaster, but clearly is actually taking more from her than she could ever imagine spending on healthcare, unless she was in the tiniest percentage of the sickest people in our country. When you talk about, to traditional health reformers, about this issue of having intermediaries pay for us and having insurance cover all healthcare expenses, as opposed to relying on a market system or our own payments to cover some of them, what they almost always say is, look, healthcare is unusual because even though we all use it over our lifetime, in any given year, 10% of the population accounts for, the number used to be 80, it's now down around 67, 68, but high 60% of all of our spending. It's very concentrated. Most of us don't use a lot of healthcare in any given year, so it really does need to be covered by insurance. This is a fundamental argument that's believed on what I call the island of healthcare. Like a lot of things believed on the island of healthcare, it's rare that anybody's ever asked the question of, does that actually make sense when you compare it to anything else? What's interesting is that almost all of us will buy cars over our lifetime, but in any given year, 100% of the cars are bought by less than 10% of the people. Almost a very large percentage of us will buy college educations over the course of our lifetime, but in any given year, 100% of the college educations are bought by less than 10% of the people. The same with weddings, the same with refrigerators, the same with houses, the same with divorces, the same with every expensive service that is widely used. In fact, what's unique about healthcare is two things that are quite different than what are conventionally understood. One is that we, in fact, for an insured good, all use some amount almost every year. Remember, this isn't like your house burning down. So an insurance pool that covers your house burning down is based on the idea that over a lifetime, relatively few of us will have our homes burned down. This is quite different. This is almost all of us at some point in our lifetime, unfortunately, are going to be in that 10% high spenders. For some of us, most of us, it'll be towards the end of our lives. For others, it'll be at other points. But unlike most insurance systems, we are not insuring against uncertainty. We're insuring against certainty, and that's created a lot of issues. Now, let's remember, as we think about building a safety net, I'm not calling for eliminating all insurance. There are some things for which we do need to insure. But when we think about healthcare, these things we believe, these big ideas like it's so concentrated, so it must be insured, when we break it down, what we realize is that healthcare can be paid for the way many other expensive goods are. Expensive universally used goods and services are, which are the predictable part, probably have to come out of pocket. The predictable major things we probably have to set aside money for. And we need to insure ourselves against the things that are unusual, major, and unpredictable. And when we try to do something other than that, all we're doing is insuring against certainty with all the expense that goes along with insuring. Now, some percentage of the population is very sick over very long periods of time. Some of that 10% in any given year are people who are in that 10% for many years. It's very difficult to construct a payment system for healthcare that doesn't insure those people and still has the values that I think most of us share about protecting our fellows against health catastrophe. But because we want to do that, doesn't mean that we want insurance to cover everybody for everything. Because then we have all of the dysfunctions that come from an intermediary driving markets, and I would argue poorly, and the extraordinary expense we add to every single healthcare expenditure we have. One of the things that people who argue for having not just universal insurance covering everybody, but comprehensive insurance covering everything, is that insurers are really good at driving the kind of price and value and service that we as consumers can't do because we're individuals. It's a complete misunderstanding of how every other market works. I always make the very poor joke that healthcare economists believe that Walmart was created when an angry mob marched on Neiman Marcus and demanded lower prices. But of course, that's not how industries work. We're not expected to do the work in consumer-driven businesses. Consumer-driven businesses mean that the companies themselves, the entrepreneurs, the new entrants, the people looking for our business, are trying to figure out ways to attract our attention, whether it's lowest prices or great service or terrific quality records, what have you. We don't have that in healthcare because we rely on the large to do our work for us. A few years ago, it's 3 years ago now, my eldest son burst his appendix. Kind of irresponsible of him, but kids. I felt like disciplining him, but my wife, who's better in these situations, said instead we should take him to a hospital where we had an emergency appendectomy. I got from the insurer the letter all of you get from your insurer when anything happens, no matter what it is, saying, can't really reimburse you for the emergency appendectomy because we haven't determined that it's medically necessary. Now, we're so used to the complexity of dealing with insurers that I think we sometimes forget that the theory behind having them do this for us is that it reduces our stress levels and increases the performance of providers and makes it all easier. In order for you to believe the insurance system has made buying healthcare easier, you really have to be a healthcare economist, because nobody else who's ever actually experienced the system can possibly believe that. One of the core beliefs that underlies our insurance-based system is that the question that public policy has to address is, how do we provide a safety net? And then how do we most effectively pay for healthcare to keep costs reasonable? And it's come to rely on what I would argue is a fundamentally naive view of how healthcare works, which is there's health problems, there's the right solutions, and all public policy has to ask is, well, how do we pay for those solutions? And of course, those who have to actually practice healthcare knows that middle piece is far more complex. The solution thing may work in the sort of auto mechanic trade, but isn't quite as good in the complexity and disaggregated nature of care for 315 million people. But what's most important, I think, about the problem with that thinking is that implicit is a point of view that the amount of healthcare received, the quality and the type of healthcare received, is not affected by how we've chosen to pay for it. That essentially how we've chosen to pay for it is a neutral actor. And I think nothing makes this clearer, that nothing makes the problem with this thinking clearer than the enormous amount of excess medicine we see in Medicare, where essentially Medicare says, and by the way, I'm pretty sure there's no other social welfare system for health on earth that has this at its core. We will fund all the care that seniors need. Sounds like an innocuous statement. Sounds like actually a very good goal. The problem is, and if you're not a healthcare person in a way, you see this more clearly. If you step back, what you see is an industry that's responded by endlessly expanding the definition of need. I will tell you, if the government is ever kind enough to say that they will fund all the game shows America ever needs, my company will be actively working to expand that definition. And it isn't a surprise that in healthcare, we see that as the industrial reaction too. Unlike in game shows, that industrial reaction has caused quite a bit of harm. When we look at some of the data in Medicare, it's extraordinary. To me, one of the most powerful studies done in Medicare looked at 1 year of deaths and discovered that 1 out of 3 patients, 1 out of every 3 patients who died in a given year, Medicare patients, had had surgery within 12 months of deaths, including 1 out of 5 90-year-olds. Now, I'm not going to play doctor because I'm unqualified to, but on a risk-reward basis, that was pretty shocking to most doctors, that many seniors were having that much surgery, that even in the year of their death, we would see that much surgery. There's a lot of complexity in that data. I know, I hear some of you saying it, but the numbers themselves are pretty damning. We know that 40% of seniors older than 75 are taking more than 5 prescription drugs, and that 20% of them have drugs that work against each other. Just a lack of coordination, an extraordinary amount of both incentive and frankly demand for pharmaceuticals creates this. We have the extraordinary sloppiness in a hospital system that's disciplined by Medicare, where Medicare itself says that 1 out of every 7 admissions of a Medicare beneficiary involves a never event. We have Medicare paying for things that its own data and its own reports and its own recommendations say should never be performed, like late year colonoscopies. And my argument isn't here's the right way to do it. My argument is this concept that a centralized way of paying will somehow be more disciplined and won't have an impact on the amount and quality of care offered, I think is already proven to be false. One of the problems that we have in a healthcare system where we've essentially eliminated real prices, right? We have costs, we have reimbursements, but we don't have prices in the sense we do in everything else. And if you ever get a bill from a hospital or anyone else, you're not looking at real prices in the sense that anyone is going to pay these, or they anyway reflect what a business is hoping to charge, is that we've built a system that has a hard time recognizing value. And I think one of the great illustrations of this is the argument over Sovaldi and the coming generation of very expensive, often targeted treatments, many of which are pharmaceutical, at least in this initial phase. We have a lot of ways in the rest of the economy to determine value. And we don't do it because everything is the same. Things are different. The most expensive model car costs almost as much as the least expensive real car. But we know that it's the model car that's expensive and the real car that's inexpensive, even though the real car has a price that's a little higher. But in healthcare, everything is about absolute price. We have a hard time doing value with the system we've built, and it's a problem all over the world. So Sovaldi costs $84,000, and in a significant number of its patients, particularly when they're targeted, as is the intention of the therapy, essentially cures a disease that can be fatal. Let's imagine that a little bit as being a little more tightly defined, which is $84,000 to save a life. We've had now months and months of discussion about these and other drugs in which people say, how can we possibly afford these drugs that are $84,000? And that does seem really expensive, except when you think about Becky. And you think about what we're putting into the healthcare system per person. It's $10,000 per person per year. If the average person lives to, let's round off and say 80 years, that means in today's dollars, $800,000 per lifetime. Now, when I think about a single drug that might cure everyone who takes it, because many of these pharmaceutical companies are talking about pay-performance models, where you only pay if it works and you don't pay if it doesn't work. That's roughly 10.5%, let's call it 10% of what we spend on someone's healthcare on average over their lifetime. And when you think of it that way, the question becomes less, wow, how do we pay for Sovaldi? As much as, what on earth are we paying for now? What's the $800,000 per person per lifetime going for if curing a potentially fatal illness at 10% of that cost is seen as too expensive? These kind of problems are problems that are going to grow as we understand, as we reach a new generation of healthcare treatments that are far more targeted, less of the blockbuster big chronic drugs and more targeted treatments designed to cure and expensive for those for whom it works. And yet we don't have a system capable not just of paying for it, which is the way people think about it, but of comparing it to things that are significantly lower value, on which we're today spending a lot of money. If you spend too much time on the island of healthcare, you're kind of used to making these statements that need real examination. And one of the biggest, and there's this chart that you see at tons of healthcare conferences. On the left axis, it's number of years of life expectancy, and on the right axis, it's percentage of GDP spent on healthcare. And you put the developed countries in, the OECD countries in, and they're all clustered around here, and the US is all the way here, all by itself, right? With relatively low life expectancy and extraordinarily high percent of GDP on healthcare, 5 points, 6 points more than any other developed country. And the point is always made, the United States is spending an extraordinary amount on healthcare and getting nothing for it. So what I like to do is put that chart up and cover the US and say, okay, so what's the pattern? And there is no pattern. Because in fact, you can look at that chart any way you want, which is that no matter how little money you spend on healthcare, it makes no difference for life expectancy. There's no line. The dots are all over the place. And of course, those of us who spend any time thinking about it realize that comparing those two variables are the problem, right? Healthcare does a lot of things, but driving life expectancy, it's fairly low in a developed country compared to all the other things that do, whether it's income or nutrition or lifestyle or weight, community safety, policing, education. All these things have greater impact on life expectancy, which is why you find that at the bottom of the OECD list in terms of life expectancy is the US and the UK, even though we obviously have very different healthcare systems. At the top, you find the Scandinavians and the Japanese and the Italians, who have almost nothing in common in their healthcare systems. But of course, they live like Japanese, Scandinavians, and Italians, and we live like Brits and Americans. And that expectation of healthcare, that it's driving so much, is not just an unfair one, but it's one that explains why we've become what I think David Brooks, in a great phrase, calls the healthcare state, where we are spending $1 trillion on the safety net for healthcare at the expense of other safety nets that, interestingly, could wind up having a much bigger impact on health. But one of the things that's important is that the narrative has very much been that the US is behind other countries who created broader safety nets that are universal, much, in some cases, more comprehensive. I think is one that's really more about most healthcare expenditures here and around the world make people feel better, have some impact on health, but only a small percentage drive life expectancy in the way that politicians talk about it. That if we don't have this bill, we don't have this legislation, people will die. Fortunately, we're a rich country that can afford to protect our whole population, but in trying to protect everybody against everything, we may have actually wound up making people less healthy because as a society, we have less resources for the things that can really matter. What did I mean when I said, can healthcare serve a new master? Well, the presumption has been, and it's certainly part of the Affordable Care Act, that the best way to drive progress in healthcare is to continue to have powerful customers at the center. The United States has a hybrid of private insurers and government, but all countries, really except for one, rely heavily on, all developed countries except for one, rely on centralized buying as opposed to the more disaggregated buying we're seeing for almost everything, right? Not just for the absolute emergencies, but for all healthcare expenditures and all healthcare costs. And interestingly enough, it looks like that's changing. The biggest change is the growth of high deductible plans. We just, in a PwC study released last week, learned that now almost every company in America, 86%, are offering high deductible plans. And that they are now the second most popular private plan. The estimates are 25 million of the 150 million employees, individuals covered by employee plans now have high deductible plans. That number looks like it's growing 20 to 25% a year. The Affordable Care Act in 2018 imposes a Cadillac tax on any employer. It's an excise tax that's very expensive on any employer who's offering a plan too generous. And in many states, traditional plans will wind up tripping that tax. No one wants to trip that tax. These high deductible plans have been important ways to save money, get under those taxes, and get employees to be more involved in determining their own care. High deductibles, which start at $1,200 for single and $2,400 for families, but can range all the way up to $6,300 for singles and $12,500 for families. You know, the first year you have one, and I've had a high deductible plan personally for the last 4, feels like your insurance is missing something. But after you're a year or 2 used to having these plans, what you realize is that for most healthcare needs, when you don't have a tragedy or a catastrophe, you're paying out of pocket. You're a cash customer for healthcare with a sort of major medical plan, like old-fashioned ones. And when I look at my own company, most of the younger people take high deductible plans. We encourage them as well to get health savings accounts so they can put aside some cash to pay for their healthcare needs under the deductible. You know, most high deductible plans still have health savings accounts, but it's not the 100% that I think is important to drive this. We also know that a significant percentage, we don't know exactly, but a significant percentage of those who bought plans on the exchanges, on the Affordable Care Act exchanges, took high deductible plans. Why do I think this is so important? I think we're 2 or 3 years away from having 40, 50 million Americans who in most years, almost all years, pay for almost all of their health care out of pocket. It's not necessarily going to immediately impact on major hospital performed procedures, but for a significant percent of healthcare interactions, providers are already reporting that patients come in and say, I'm paying out of pocket for this, I want to know what the price is. Or I want to know the total services being offered, and I want to know there's no bills later that I'm going to be hit with. Now, at the beginning of what I think is likely to be a consumer-driven healthcare revolution, that's what we're going to see. We're going to see patients with high deductible plans demanding price quotes and demanding service explanations and demanding bills they can read and information they can keep and understand. That's the beginning. But what happens in most industries is that new entrants, new or entrepreneurial providers say, well, wait a minute, this is an interesting business opportunity. Because particularly among younger generations, who are used to buying absolutely everything in a different way than, frankly, people of my generation did, the healthcare system is completely unsatisfactory. And as they think about buying things out of pocket, they feel less reliant on the insurer and more interested in a relationship with a provider or a series of providers or a different type of health intermediary that looks more like what they see in the rest of the economy, that remembers them the way an Amazon does, or that allows them to read reviews and descriptions that other patients have had the way a TripAdvisor does, or that's convenient and to order the way an Uber is, and customizable in that way, and that allows them to keep their own records. This is what a significant percent of our population expects for everything. And when they're paying for healthcare out of pocket, the opportunity for people in the industry, the incentives I talked about at the beginning of my talk, is going to change. Because throughout the history of our intermediary-driven healthcare system, nobody really made more money by saving money for anybody, by reducing costs, by being more efficient, by being better at service. No one really did better by doing better for the customer in a way we saw in everything else. That key incentive, at least for those who have high deductible plans, I think is going to change. And I think for serving those customers is going to change. And I think that when you look at 40, 50 million people having high deductible plans, thinking about most of their spending in most years is out of pocket, we will have an enormous change in not just the psychology of the patient customer, but in the psychology of the provider that, to be crude about it, wants their business and wants to retain them and wants to build a relationship with them. This is critical mass, and we haven't had critical mass among people with money in healthcare essentially since 1965. Kenneth Arrow, 51 years ago, wrote that you could never have a normal consumer business in healthcare because there's something called information asymmetry. The provider, in economics terms, his terms, the seller knew so much more than the buyer, the patient, and had an unusual marketing hook. You know, in lots of industries, the seller knows more than the buyer. The guy selling you a car almost always knows more about the car than you do, but he can't say what a doctor can say. Buy this or you'll die. And Arrow's point was that perceived urgency of the transaction by the consumer meant that consumers could never operate properly in healthcare. Very powerful argument. Arrow, of course, is a Nobel Prize winner, a brilliant man, and one that is the foundation of healthcare economics. Now, Kenneth Arrow didn't know about the internet 51 years ago. And he didn't think about what was the alternative. His argument was you needed intermediaries to drive the system because only they could be dispassionate and could negotiate with providers and could assure that a correct amount of care was prescribed at the correct price. So we are roughly 50 years into doing what Kenneth Arrows and his successors proposed. And it's done the opposite of what we had hoped. We have far more excess medicine than it would be possible to imagine if we had consumers with their normal skepticism. My own grandmother, if you asked her to spend $1 on a medical treatment, would have been very skeptical of the need. We've lost that skepticism. We have none of that obligation to serve the irrational, emotional consumer that drove us to make sure soda stains were cleaned up in a movie theater so that a couple would come back next weekend on date night. We have none of that in healthcare because we've taken the consumer out. And of course, that's not about soda stains. That's about service, navigability of the system, complexity or lack of complexity, simplicity, all the things that are crucial in healthcare. And interestingly, Arrow obviously also could not have anticipated that the internet changed information asymmetry. Many providers actually complain that patients come in telling them what they want to be prescribed for their self-diagnosis in a way that would have been inconceivable at Arrow's time. And obviously, a lot of the reason we see so much television advertising for pharmaceuticals and devices is to get patients to do just that, to turn around that demand. But patients are obviously not only more sophisticated, but capable of being more sophisticated. But one last point that Arrow could not have foreseen, and that the whole healthcare system, the foundation of which has not changed in response to. 50 some odd years ago, healthcare was seen as something that was relatively rare, often urgent, and often major. That you had something and you had to have some response, some treatment. Fast forward 51 years, in part because of some of the successes of healthcare itself in treatment. The overwhelming share of the healthcare dollars spent today on chronic conditions, and the overwhelming number of even major conditions are chronic. And by chronic, what we're talking about are things that are going to be treated over long periods of time that often involve choices. They may involve trade-offs between lifestyle decisions, pharmaceutical regimes, surgery, rehab, other forms of alternatives that require the patient to make a decision in a way that was inconceivable when Arrow wrote. A significant amount of interactions between the system and the patient now is, here are your alternatives. Which direction do you want to go? But unlike the rest of our economy, that's hard to navigate for a patient. Understanding those choices are difficult. I argue that's because the patient is no longer the customer in almost any healthcare interaction. And I would argue that divergence between being really the goal of care, which is to improve the patient's welfare, and the nature of the customer in healthcare explains so much of what's gone wrong in healthcare and so much of what could go wrong. We talk about money way too much in healthcare. We spend way too much in healthcare. But what we miss, I think, is that the other elements of a consumer-driven industry are crucial in healthcare. And they're certainly crucial to this next era in which treatments are going to be more personalized, alternatives are going to be broader, patients are going to need to be smarter, and the integration between care and lifestyle choices becomes ever greater. I'm an optimist because I think we're going to get to critical mass in high deductible payers, people who think of themselves as cash payers for most healthcare needs, and that the industry, like other industries, is going to transform itself to serve them. And that even those who are not cash payers, and even those services that may be covered by insurance are going to benefit from it in the same way that my mom on her smartphone benefits from Apple's efforts to get all the 20-somethings to love their features. I think that can happen in healthcare, and I think that's an extraordinary opportunity. But on the political side, one other thing needs to happen before we accept the possibility of this transformation. And that is to tie the big picture to the little picture. Healthcare has been a divisive, major national issue for a long time. But we talk on the island of healthcare policy as if the things we know in the rest of the world can't possibly apply. That's the big picture. At the same time, there's the little picture, which is now 315 million people, each of whom have at least one story of something that happened in healthcare that's inconceivable in something else. Some absurd wait in a waiting room for a very expensive professional who presumably wants your business. Lost paper files, mix-ups between one specialist and another, prices that make no sense, services that you don't know you were billed for, bills that come in months and months and months after a procedure for an incomprehensible amount of money, and communications from your insurer who's working on your behalf that are intentionally unintelligible, all the way to the more severe ones. Excess medicine, error, accidental death. We're never going to resolve all of these things. Healthcare's big, complex, and important. But we can start to bring in the disciplines, the disaggregated force that consumers are into healthcare in a way that will at least change the incentives of all of us, patients and providers. I thank you for the time. I appreciate your inviting me. I'm sorry I couldn't be there in person. I look forward to hearing the feedback. Thanks again.